So welcome everybody to Grand Rounds Special Topics, May 31st, 2023. Today we have Devin Knox presenting on providing care to bilingual patients as a monolingual therapist. So thank you everybody who attended in person and to everybody who is attending live online and also watching the recorded version. Make sure that you use the QR code on the screen in front of you to log in to EADS, take the quiz afterwards, and complete the course evaluation so that you can get credit. For those of you speech therapists, make sure you also complete the ASHA form so that you can get ASHA credit as well. Ms. Knox earned a dual bachelor's degree in speech, language, and hearing, and also Spanish from Temple University. She earned a master's degree in speech-language pathology from George Washington University. Ms. Knox first learned Spanish beginning in first grade through a Spanish immersion program offered by her school. She continued her Spanish education throughout her college career and studied in Costa Rica. Her practice focuses on pediatric speech-language pathology, and she works for St. Luke's University Health Network. She provides speech-language pathology services for pediatric patients who are exposed to Spanish and/or English at home. So without further ado, I will turn it over to Ms. Knox.
Hello, thank you everyone who's here and who is also online. As Steve said, I am Devin. I am a pediatric therapist at our Center Valley Lanark Road location, and I work with mostly patients who are exposed to Spanish and or English. I'd say about 80% of my caseload at this moment is considered bilingual or is only exposed to Spanish. And then the other 20% is monolingual English. So yes, today I will be presenting regarding providing those bilingual patients with care with occupational therapy, physical therapy, and speech therapy as monolingual therapists, as most of us are. I will be providing a lot of examples about Spanish English because that's my experience. However, I want everyone to know that these tips are not just for our patients who are exposed to Spanish and English, because we're not only going to see those types of bilingual patients. So again, I might use a lot of Spanish examples because that's my experience, but please know it doesn't just restrict us to using this information for our bilingual Spanish-English patients. Also, I'm going to provide a lot of examples about speech therapy, specifically pediatrics, as I am a pediatric speech therapist. However, the information can also be used for physical therapy, occupational therapy, and adult speech therapy as well. But I might say kids or parents, things like that a lot, just because that's my world. Try to get our slide to change. Oh, there we go. Let's make sure it stays on this one though. Sometimes I move faster than the computers. All right, so the statement of need has been put out previously, but here on this slide we have the statement of need and the description of the course that we will be doing today. I trust that you all can read, so I won't read it. The first few slides I'll kind of fly through. This is our designation statement. Again, information that if you are interested in will be located on these slides. And then also our disclosure information. I have no financial relationship to disclose for this presentation. Now we're going to move into a bit of the meat of the presentation. These are the learning objectives that I hope that we're going to be able to cover and everyone will feel confident with once this presentation has completed. So our first objective is that our participants will recognize and implement best practice when assessing and treating patients who are exposed to other languages. Again, I might use a lot of Spanish, English examples in this presentation, but this information can be carried over to others as well. Participants will be able to discuss best practice when assessing and treating bilingual patients, and will be able to execute evidence-based treatment techniques for future therapy of bilingual patients. And also, participants will be able to design these treatment plans to make them appropriate for our bilingual patients. I wanted to start off with a little bit of demographic information. On this slide, I only have Allentown and Bethlehem detailed, but I do also want to acknowledge our New Jersey, as well as our Reading area, Easton as well, also has a very large Spanish-speaking population. I just only had so much room. This information is a combination of from our most recent census, but the most recent census did not ask about language exposure. So the information about language is from a previous census. So just know that this might not be totally accurate for today in 2023. In Allentown, 53% of the residents identify as white and 54.5% of residents identify as Hispanic. 47.3% identify as utilizing English only, whereas Spanish is identified in 44.4% of households in Allentown. Again, this is from 2016 as well, this information. So it might even have shifted into a higher percentage of Spanish-speaking households in Allentown. At that time, also about 13% of individuals in Allentown describe themselves as limited English speaking, so only having maybe a few words in English, but majority in Spanish. For Bethlehem, we see similar statistics, not as close, but identifying as white at 68% and Hispanic at 30%, English only at 71%, and Spanish only at 23%. So we see this area has a very large Spanish-speaking population. I'm sure we've all treated patients who either are only exposed monolingual Spanish or are bilingual Spanish-English, but that does not eliminate the possibility that there's other languages spoken in this area that are not Spanish and English. As we see in Bethlehem, 3% of individuals identify as Asian. I know we've had patients come through our clinic who are exposed to Russian, Portuguese, and a variety of other languages. I do want to touch on some really important bilingualism key terms. These are key terms not only for this presentation, but also key terms to use in our practice. The first two are describing individuals who are either learning language or exposed to two languages. It used to be more called English as a second language, ESL. Research articles and academic papers have moved away from those terms and are using English language learners, which is individuals learning language, and dual language learners. That's individuals learning two languages. It's just a bit of a more all-encompassing term that doesn't just talk about learning English or Spanish. It's so that we can be a little bit more inclusive in our language. There are two types of bilingualism. There's sequential bilingualism and simultaneous bilingualism. For sequential bilingualism, usually the patient will learn one language fully before learning the second, before the second is introduced. And that second language is usually introduced after the age of 3. However, you might see in some research saying 18 months, but more research says age 3. So, but just a heads up, if you see 18 months, there's kind of a little bit of a fight back and forth between age 3 and 18 months. Simultaneous bilingualism is learning both languages at the same time, usually the second language being introduced before that age of 3. We then have a few other terms that refer a little bit more in the speech therapy realm, but we have code switching. The official definition of code switching is switching between two languages in the same sentence. However, I'm sure we've all heard this term before used for dialects and also switching back and forth between two languages after a sentence is complete. I use the term a lot as I switch back and forth between English and Spanish throughout my day, and I talk about how I code switch back and forth. Language transfer. This is a very important topic that I'm going to touch on a lot throughout this presentation, especially when we get more into the meat of the evaluation and the treatment process for our bilingual patients. This is when we take the rule from one language and we apply it to the other. For example, with Spanish and English. In Spanish, the adjective will present itself after the noun. So, un carro azul. In English, we put the adjective before the noun, a blue car. So if, for example, patient in English said a car blue, we're seeing language transfer there. We're seeing the generalization of rules from one area to another. And that might cause errors in the patient's morphosyntax. However, it doesn't necessarily indicate a delay or a disorder. So we need to be conscious of those language rules. We then have silent period. Again, this is a really important term for us speech therapists, especially us working with the pediatric populations, because this usually occurs during the initial stages of the second language acquisition, when that child is really focusing on listening, so they tend to go quiet. And this is a very individualized experience. I was recently watching a continuing education where one presenter stated that her silent period was just a few months, whereas her husband's silent period was 2 years. So it really does depend on the patient, and how we kind of get through that I'll discuss. One thing I missed putting on here, I made some edits post, is also the term L1. I'm going to be talking about that and you might see it. L1, L2. L1 is first language exposed to, L2 is second language exposed to. So if you see L1, that's usually what we would call like our the native language. Myths about multilingualism. I have either heard all of these in my practice from parents telling me what other maybe providers have said, doctors, or also just hearing them in mainstream society. One big one that I hear is exposure to multiple languages is confusing. It is not confusing. Individuals who are presented with multiple languages, there is no research to say that it causes any kind of confusion or delay. Another one I hear quite frequently is children with delays should only be exposed to one language. There's also no research to support this, and we should not be telling our patients this. We should be telling our patients that they should speak the language they feel most comfortable with at home, as there is no research to back up that it is at all causing confusion. Another myth is that sequential language learning is best. And that's not true. So learning one language fully and then learning the other, again, there's no research to support that. Simultaneous bilingualism and sequential bilingualism both have their merits and are both wonderful ways to learn languages. Monolingual parents cannot have bilingual children. My parents only speak English. I speak English and Spanish. I spoke Spanish for my entire elementary school, and we got by. I have plenty of patients who speak English and Spanish, and their parents only speak Spanish. And monolingual parents are able to raise beautiful bilingual children. A big one I hear a lot is that parents should pick one for children with delays. I have heard that mom should speak English and dad should speak Spanish as well. Again, there's no research to back this up. We should not be providing a recommendation that one language be picked. We should be encouraging that any language that the parents and the family feel most comfortable with is used in the home. And then the last one is that everyone should learn English. The United States does not have an official language, and being bilingualism is wonderful. There's a lot of research to promote bilingualism in childhood education, and it's not everyone's priority to learn English, and we need to honor our patients and the patients' families for what they would like as well. I want to delve just for a second into the code of ethics of each American Speech and Hearing Association, AOTA, and APTA, because I think it's important for us to just always be reminded of the code that we follow. So specifically for ASHA, it states in the code of ethics that we shall not discriminate delivery of services based on language. We cannot be denying patients services just because they do not speak English. It is against our code of ethics. I know sometimes that we feel it's unethical to provide services that in a language to a patient that doesn't speak the same language as we do. But in reality, that's actually what our code of ethics says, is that we are to provide the services no matter the language. And I'm going to give you the tools today to kind of work through that. Obviously, it creates more complications, but there are tools that we have so that we can still continue to provide effective treatment for these patients. AOTA is similar. We are not, OTs are not to discriminate against anyone regardless of age, gender identity, sexual orientation, race, religion, origin, or socioeconomic status. And again, similar with physical therapy as well, they shall not discriminate against patients due to age, gender, race, nationality, religion, ethnicity, social or economic status, sexual orientation, health condition, or disability. So we are bound by our code of ethics of our professional organizations and as healthcare providers to provide the best services we can to every patient. As we start to get into the meat of this presentation regarding the evaluation and treatment of our bilingual patients, I think this is very important to note. It has been suggested that language impairment and other disabilities may be under-identified in young dual language learners, but over-identified in older dual language learners, as clinicians and educators begin attributing children's lower achievement to factors other than limited English proficiency. In the pediatric world, we see patients from 0 to 21. So this is important to keep in mind as we are seeing those younger patients that are before school age that are under-identified for language impairments. But then when we see our school age patients, they might be over-identified. And this also could impact occupational therapy and physical therapy as well in the recommendations due to that language barrier. All right, let's get into it. Evaluation, the basics. I'm going to have a few more slides regarding specifically the evaluation process, but I just want to introduce. Utilizing the interpreter service is incredibly important when we are working with a patient whose native language is not English, whether that is the patient or the family member. We want to use that interpreter service, the CERCOM video if we can, and if not, the telephone service. I know it might seem obvious, but we do want to be conscious of our space selection when we are using the interpreter. That might be the time that we ask to have that closed door evaluation room if possible, eliminate some of the noise so that the patient, the parents, and the clinician are able to kind of listen to the interpreter. The iPad volume only goes so high. We want to familiarize ourselves with cultural and linguistic characteristics of the patient's native language. These evaluations are going to take a little bit more time before in preparation and time after in analysis. So we want to make sure that we're providing that additional time to ourselves as the clinician to make sure we are fully prepared, that we understand the cultural expectations of our patients to provide that culturally competent care, while also understanding the linguistic characteristics of the language as well, especially for speech language pathology, so that we do kind of know what we're getting into, so that we are already familiar with the norms, so that we can make better recommendations. We want to make sure the documentation is in the patient's language. Anything they're signing should be able to be provided to them in their language. That's case history, attendance policy, the patient consent, all of those forms should be there and readily available in any language that our patients speak. We do not need to understand, though, that there are some nuances that are lost when translating English to non-English. I did my very best with the pediatric attendance policy in Spanish, but again, when you're going right from English to non-English, you might lose some of that. So it's always also a good idea to review those forms with the interpreter present, so that if the patient does have any questions of something that was lost in translation, that we're able to address that so that the patient feels comfortable with the information that they're signing. Again, additional time might be needed for these evaluations. We're going to need to take a little bit of time before to fully prepare and time after to make sure that we're providing the best recommendations for our patients. So we just want to keep that in mind. And then the importance of case history. This is incredibly important during this evaluation process, and I am going to get into this a little bit more in the next slides regarding parent questionnaires and family questionnaires for adult patients as well, so that we can get a very full, robust background information, because that is going to help us when we're making those recommendations, as other tools that we would usually use with our monolingual patients just might not be a good fit for our patients who are not monolingual English or bilingual. A little bit more about the use of the interpreter. As I said previously, we might want to take a little bit of that time before the evaluation, and a little bit of that time directly before the evaluation might also be getting the interpreter set up prior to having the patient come back to the room and sharing the goals and objectives of the session with the interpreter. I don't mean the treatment goals and patient will identify age-appropriate vocabulary kind of goals, but what you are intending to do during the evaluation or the session, and also what you would like to have done during the evaluation. It gives the interpreter a heads up of also knowing what the expectations are, and can also assist you in getting that information. We also want to use that interpreter to explain the why of what we're doing, especially when we're working with pediatric patients, but this goes for adults as well. We will be providing care for patients who do not necessarily have the same culture we do. Things that we might view as not rude might be viewed as rude in a culture. For example, shaking someone's hand. If it's a male and a female, in some cultures, that might be viewed as rude. Pointing in some cultures is viewed as rude. So if we're having evaluation measures and activities during the session that incorporate a lot of pointing, it's a good idea to have the interpreter explain to the parent and the patient why you're doing what you're doing so they can understand. And if it's a parent, encourage their child to participate, even if they've been told, hey, don't do that, that's rude. The clinician is asking you to do this for a reason. For all fields, we need to understand the impact of standardized scores using an interpreter. This will be located in the manual, but it's good to check beforehand to make sure that you're still able to reach a standardized score, even with the use of an interpreter, because if you think about it, if the patient does understand English and Spanish, they maybe will be then listening to the stimuli twice. So again, just little things to think about. That is just checking in the manual, contacting the testing company. Then the age-old question of utilizing family members as interpreters. We have a lot of individuals who come in and maybe their other children speak English and Spanish, or another family member, a friend. And there's just a few things we want to consider before we go with that route. We want to consider, what is the message? Are we providing a diagnosis? Are we going to be having a difficult conversation that might, first of all, be difficult for the interpreter, the family member, to hear, and then even more difficult to relay to their family member? Are they going to potentially alter that message because it might be a difficult conversation? We also want to consider the age and position of the family member. Is this a 10-year-old child that we are asking to interpret a conversation regarding their 3-year-old sibling's language abilities, and that we're providing them with a mixed expressive receptive language disorder? Do we really want to put a 10-year-old in that position? Then we also want to consider the reliability of interpretation. We're using medical terms when we're talking to these families. Are we expecting that 10-year-old may have that vocabulary in both languages to fully share that message? So if a family does want to utilize a family member, I think it's still a good idea to have the interpreter service on, just in case we are having there's difficulties with the translation. But again, I know that it is a difficult position when the family is pushing for another family member to be the interpreter. Something very important to consider when we're using the interpreter service. Clinicians must do their best to ensure that services provided are reliable and must make every effort to become familiar with the client's language, whether that be language structures, phonemic inventory, how translation and interpretation may impact the message. We cannot just fully rely on the interpreter. We also, as the clinicians, although this is from the American Speech and Hearing Association, this is across the board. We must make sure that we are doing the work to be prepared for these evaluations and have this background knowledge, because at the end of the day, it's our responsibility. Standardized measures when evaluating patients who are multilingual or who are not exposed to English. Again, we want to understand the impact of translation on standardized testing, whether that is just doing the research to see if the interpretation of a test using an interpreter is allowed, or when it comes to especially language testing for speech language pathologists, are we still testing the same thing? It's the self in English is not the same thing as the self in Spanish. We cannot just be directly translating these standardized measures and then calculating a standardized score. First of all, there's a lot of differences between the languages. Phonemic inventory, morphemes, syntax, vocabulary. There's different developmental norms for different languages. So again, we want to be conscious that we cannot take a test that's in English and then just translate it using the interpreter and take those scores as being standardized. We also want to take into the consideration those cultural differences. Are these testing materials appropriate for other cultures that we are testing? Many standardized tests are based off of norms from the United States. So we want to make sure that we are also considering that cultural aspect. And again, that does take that research a little bit beforehand to make sure that the testing measures we're using are culturally competent and respect the patient's culture. Especially for speech language pathologists, we want to also consider utilizing non-linguistic measures. There's research to state that utilizing non-linguistic measures can also indicate a language disorder. It is not black and white. It cannot provide us with a diagnosis just as is, but it can be a tool in our toolbox of this evaluation process to help us form the best recommendations possible. So that's something to keep in mind, utilizing those non-linguistic measures and not just always relying on that understanding verbal speech, output of verbal speech. The extensive diversity of linguistic experiences among bilingual children poses a challenge in designing language assessments and screening tools. This is not easy. This is not an easy process. This is something that does take a lot of time. It takes a lot of preparation, and it's not easy for me either. I'm not terribly thrilled with the bilingual language measures that I have. I don't think that they're terribly robust, and it's definitely an area in our field that's lacking. They're working on it, but it's very difficult to assess. Even if you do speak both languages, it's still very complicated. So I want you to always remember that too, that this is very complicated. So it might take a little bit more work and a little bit more components, more of those tools in our toolbox. One of those tools that can be very important, and again, this is across disciplines and across outside of therapy, is dynamic assessment. Dynamic assessment focuses on learning in response to that support or feedback. So it helps us determine, is this an area of need because there's a disorder in the learning of the skill, or just the skill hasn't been taught yet? So this dynamic assessment sort of helps us kind of parse through that. There are two types of dynamic assessment that have specifically been studied for dual language learners. That's mediated learning experience and graduated prompting. Mediated learning experience supports a little bit more of that individualization and adapt the stimuli, the environment, and the information that's presented to the patient, whereas the graduated prompting method has more of a scripted prompt. There's slightly more research to suggest that graduated prompting is a bit more successful with bilingual patients, but again, both areas of dynamic assessment and any area of dynamic assessment is a very strong tool to use when providing evaluations to bilingual patients. I do have a short video here. It is from a website called Bilinguistics. I thought that this video had a lot of really great images to kind of help break down dynamic assessment in speech language pathology. Oh no.
We've all finished a form evaluation, found that a child qualifies, and you either don't really believe the results and wonder if culture, exposure, attention span, or something else is influencing the scores, or you know the child qualifies, but don't have a clue how to write goals to get him to move forward. Here are 4 steps using dynamic assessment to help you identify if a child should qualify, how much support they need, and how to determine what goals to write. Step 1. Choose an area on formal testing where the child did not do so well. Step 2. Attempt to teach the skill. Here's the problem. If a child gets something wrong, is their second language influence or lack of learning experience causing the skewed results? Well, if we're able to teach the skill and the child learns quickly, chances are they do not have a deficit in this area. It's a 5-part process and looks like this. Intentionality. Let the student know exactly what you are working on so that they know that it's not just a game or activity. Meaning. Tell them why it is important. Transcendence. Explain what happens if they don't know how to do what you are asking. Application. Clearly say what you expect her to say or do and give an example. And competence. Retest to see if the child can perform the task or answer correctly. This may seem utterly simple, but you are not trying to see if a child has a skill. Your test results already suggested that they don't. You're trying to see if they lack the skill because of life experiences or lack of exposure to the academic topic. If they can learn the skill rapidly, they probably shouldn't be on your caseload. Step 3. Record how much you had to support the student. Take accurate notes on how you helped the child. This is very important information for the teacher, especially if you're not going to qualify the student. Step 4. Determine whether this language area needs to be addressed with therapy. You began with a child not performing as well as they should for their age and situation. Have you been able to influence that? If you were able to teach the child quickly, it is not a good goal. If he improved his performance, but he needed your help, you have a great goal and also documented level of support. We created a dynamic assessment protocol, and you can download it for free from our website. And check out this online course to learn how to do dynamic assessment quickly and effectively.
Oh, right. Bilinguistics has a lot of really great resources, just a little. We can get to our next slide. There we go. All right. So the parent questionnaire, this is an area I slightly touched on before, but it is a really important area to consider when we are evaluating any bilingual patient. It doesn't have to be a parent questionnaire. This could be a family member questionnaire as well, for patients who may have had a stroke. So determining what their prior level of functioning was. So we can use parent questionnaires, family questionnaires for all of our patients. This will provide more information regarding a patient's skills across settings. So not just the 1 hour that we might get to spend with them, but across. For school age individuals, that teacher input might also be important so that we get that better picture and we get a little bit more information about how the individual is utilizing their native language if they primarily use L1 at home and maybe at school. So it's important to receive descriptions and comparisons of the skills and concerns. This is going to have not maybe how many words does your child have, but what kinds of words does your child have? This might be utilizing some tools outside of just the case history to get a little bit deeper into these questions so that these parents or family members are describing exactly what the patient does or what the patient does not. Comparisons can also work in our favor. What has patient's cousin, who is the same age, done versus what the patient has done? So we can kind of use those comparisons, or what does the patient do now and what did they do before the event? A very good questionnaire is called the ITALK, the Inventory to Assess Language Knowledge. So that's just an example of a questionnaire, but you can either build your own, and I'm sure that there are resources online for parent or family questionnaires as well. So to finish up the evaluation part, we always hear this difference versus disorder. We want to use the converging evidence of all of the tools in our toolbox that we just talked about to provide those recommendations. So we want to use those questionnaires. We want to use speech samples. We want to use that dynamic assessment, the learning potential, and we might also want to use those standardized tests as well, and just understand that we need all of these components in order to make the best recommendations, and we can't necessarily rely on all of the tools that we use for a patient who's only exposed to the language that we speak during therapy. Now for the treatment, the basics. Treat in the language you are most comfortable using. If you're most comfortable using the English language, treat and provide therapy in that language. If you have a few words in another language, make sure you're still treating in the language you feel most comfortable using. And maybe you can throw in the word here and there. However, just know that you should be treating in the language you feel most comfortable. We want to build relationships and rapport with families. This is very important. These treatment sessions might look a little bit different than other treatment sessions. There might be a lot more family in the room with you while you're treating. We might not leave mom and dad in the waiting room. We might bring them back into the treatment room so that not only what I'll touch on later is kind of doing a lot more parent training, but having that family involved and building that rapport. There's different levels of trust of medical individuals across cultures. We need to build that relationship so that our families trust us in the treatment that we're providing. Use your resources. Pediatric therapists, teachers pay teachers. It's always our best friend. So continue to use those resources. Use the tools you have in your toy closet or in your materials room. There are a lot of materials that are not in English or Spanish. Mr. Potato Head is in every language. So use those resources. Don't feel like you need to have separate materials for your patients who speak English and Spanish. You can kind of adapt the materials you do have. We want to continue to use that interpreter during treatment as well, especially when the parents are involved, because we're going to be relying a lot on that home program. We're going to be relying a lot on those recommendations that can be then implemented at home in the native language. So again, we want to continue to use that interpreter so that families fully understand what we are saying. And we want to support the L1 of patients. We do not want to push that English is the be-all, end-all language for them. We want to continue to emphasize the importance of the skills that we're working on in therapy also be implemented with their first language, their native language at home as well. For treatment, there are a few different areas that have been studied the most for dual language learners. First is the caregiver-based recommendations. So this is in enhancing that caregiver and child interaction, or enhancing the caregiver and care receiver interaction. So we want to still continue to make sure that we are fitting this intervention style to the cultural background and interaction style of the patient. Not every culture has the same parent, child, or family member dynamic interaction style. So we do want to make sure our recommendations are still respecting the interaction style of that culture. We want to utilize the teach, model, coach, review approach. So this is teaching the skill, modeling it to the parent, coaching the parent as they're doing it, and then reviewing at the end. The parent might be down on the mat with you, playing with their child, and you're coaching them through, using the interpreter, how to model language, how to do treatment plan A with toy A, so that they can take those skills and then continue them at home in the native language. We also want to talk about the naturalistic communication intervention. So that's taking what a child is interested in that moment, engaging in that moment, and building off of that. So if they're in the car and the patient is talking about a car, working with the parents of how to take that information in that natural environment and expand on it. Then for interaction-based recommendations, for us as well, we always want to encourage wait time and time delay. It's a tough skill. It's a tough skill for us to learn as speech therapists and other therapists as well, but working on it and coaching parents through that as well, providing that wait time, especially for individuals who are processing maybe in 2 languages. We want to kind of give them that additional time, and for the patient to be able to have a chance to respond. We want to work on those responsive child-parent interactions. As I said before, with the naturalistic communication intervention, if the patient is involved, if playing with a car, how to respond to those interactions and have joint activities around those child's interests. So how we can kind of make that group interaction around the child's interest. Again, we always still want to continue to respect the cultural interaction style. If this completely goes against what the parents say is their cultural interaction style with their child, we also have to work with that. Then we also want to consider multi-party interactions. We want to have siblings involved, other families involved, friends and family that might be in the house a lot. We want to have them involved in therapy as well. Maybe that's just sending a handout home so that, we might not be able to have everyone in the treatment room with us, but we do want to acknowledge that we want everyone involved in this process. For language strategies, they're not much different than the language strategies that we utilize with other patients. We just need to understand that we might be utilizing the interpreter service and that we're going to be coaching the parents utilizing these techniques at the home in the native language as well. Expanding on child's comments, using storytelling, that focus stimulation, thinking of only 2 core vocabulary words you're going to use during the session and really focus on them. Again, these are techniques that we utilize with many different types of patients. We just will want to emphasize these to the parents and use that interpreter while we are providing this kind of care. We also want to be aware of the cross-linguistic influences that might occur. So again, that's kind of where that pre-research comes in of understanding the linguistic structure of a language or understanding a cultural norm for the patient for occupational therapy and physical therapy. So we want to be aware of that so that when we do potentially see that, we're not marking it as an error, we're just understanding that there might be influences from the other language on the other. Then for our older patients, that early literacy strategies, again, these are not that different than the strategies that we might use with our patients who are not exposed to two languages. So we want to engage in those shared storybook experiences. We want to be asking questions and working on those questioning strategies. We want to be creating experience books of personal narratives for the patients as well to work on some of those early literacy strategies. And again, with the support of the interpreter, while also providing the parents with trainings of how to complete these strategies in the home as well, so that while the therapy in our office might be conducted in English, the carryover can be conducted in the patient's L1, so that we are basically still providing the therapy in both languages because that carryover is going to be in the native language. I want to briefly touch on culturally competent care. This could be an entire grand rounds in itself. There's a lot of information regarding culturally competent care and how important it is to patient outcomes. I only have a few minutes to touch on it, but I did because it's incredibly important, and I've said those two words a lot today. There's a lot of research to suggest that matching a patient and provider culture improves patient outcomes. That is not always possible. We cannot always match a patient with a provider of the same culture. We can try to, but that's just not always possible. But I did want to state it as it is. The research does show that there are better patient outcomes when the culture is shared. We want to provide that culturally specific care. We want to adapt the materials we have to match the patient's culture and linguistic needs. We want to build that relationship, show that we respect their culture as well, because this truly does, the research shows that it directly correlates with patient outcomes. And again, we want to have that family involvement. This graphic is taken from a research study that is cited on my sources, but this kind of breaks down a little bit of the cycle of culturally competent care. It addresses the organization's role in culturally competent care, administration's role in culturally competent care, and then also the individual level of culturally competent care. Here at St. Luke's, we do have a strong investment in providing culturally competent care, and it is that full circle. It's not just one or the other that has to be addressing this, but it is us as an entire team that need to be focused on providing that culturally competent care so that we can be providing the best services possible so that we can have the best outcomes for our patients. Thank you, everyone, for listening. Again, my name is Devin Knox. My email is listed below for anyone who has any questions that they do not want to share today. Also, anything that comes up with patients. There is, for our pediatric staff, a bilingual speech and language pathology referral protocol that has been emailed out a few months ago that you can refer to when working with a bilingual patient to see what the best referral process is for myself and for the other individuals on our bilingual speech therapy team. Again, I'm located at Center Valley Pediatric Therapy, and the phone number is there if you want to call us, but email is always better.
If anybody has any questions, feel free to unmute yourself and ask, or just type it to the chat. But we do have one question. All right. Adding the interpreter service definitely increases the length of time that it takes. So what is the appropriate length of time for an evaluation that requires an interpreter?
Oh, I think that depends on the patient, depends on the therapy, depends on the concerns that the patient is coming in with. I think that that's tough. It might be that you have to schedule a follow-up to complete the evaluation process. We do tend to, at least in the world of pediatrics, schedule for 1-hour blocks. And we do have other patients that we are serving. So we might only be able to provide that 1-hour block for that evaluation that day, but we just might not want to have it in mind. And even to alert the patient beforehand, we might need to schedule a follow-up evaluation to complete everything that we had on our to-do list for the evaluation before providing recommendations. We have to do that sometimes with monolingual patients as well. We have to complete the evaluation at another appointment just because it's a long process. So unfortunately, I can't give you a specific hour number, but I just think it's a good thing to keep in mind that you might have a follow-up eval that needs to be scheduled to complete everything.
It's over the people, and it's almost like Asian is part of this second one. And just like that 5-minute review real quick at the end in the hallway where it's like
nuts. Yes. Yes, I'm going to repeat the question now. Brandy asked about if we, especially in pediatrics, I'm not quite sure about in the adult world, we tend to have that 5-minute wrap up at the end with parents about what happened in the session. And if, because we're utilizing the interpreter, if the family should be more involved in the session or if that time at the end should be longer. Every case is a little different. We have parents come back or not come back for a lot of different reasons, especially in pediatrics. I think that in an ideal world with an ideal session, the parent would be involved in the treatment session. We would have them be back there because it's going to be more heavily, a more heavy push to parent training than providing the skills to the patient and then giving that quick wrap up. It's almost like our whole session is parent training so that it can be carried over in the native language. So again, every case is different. We know that working in pediatrics, but ideally we would have the parent and family members. Mm-hmm.
but she didn't see how.
Exactly. And I think that's why there is we almost have to reframe our mind that it's not only just treatment sessions, that these are parent training sessions or family training sessions for adult therapists. It's going to look different than when we're working with our monolingual patients. And that's okay because it's different therapy.
Another question. What are your thoughts about administering an assessment in which you have to rely on parent report rather than the assessment? Rather than the assessment, some parents may perceive their child's skills higher than what they truly are.
We run into this with monolingual patients as well. So I think that, again, that's why we have a lot of those tools in the toolbox. We're not just relying on standardized testing. We're not just relying on dynamic assessment. We're not just relying on parent questionnaire. We're taking it all as well as our clinical judgment. And that is what we're coming together with the recommendations. That's also where that comparison, I was reading a lot of research. And that's kind of where that comparison aspect comes into, because you're right, we do get that a lot, where a parent might say, oh, well, Johnny can do this, that, and that, and that. And you're in the treatment room and you're like, that's kind of where those comparisons come in of how does your child interact with this toy in compared to their sibling. Again, we know as clinicians, everyone develops differently, but it might give us a little bit better of an idea. And then it also might give the parents a better idea too of, oh, no, my child is using 10 words at 2, whereas their sibling was using X amount of words at 2.
Okay.
Yeah.
Other questions?
I was going to say, anybody and people who don't want to pose their questions in the chat or anything can also email me any questions. I love to talk. So.
Right. And again, thank you very much for attending. Please make sure you scan the QR code and/or log in, complete the quiz, complete the course evaluation, and then you can get your credit. And for those ASHA people, make sure you get your ASHA form, complete it, submit it, and then you're all good. If you have any other questions, please feel free to contact Ms. Knox. Thank you very much.